Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Heme podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our AML journey, our MDS AML journey, and this time talking about diagnosis and risk stratification of these diseases, those important things that we need to do in order to take that next step when we figure out treatment modalities.
Yeah, really excited to get into this one. We're going to provide everybody a review of that bone marrow biopsy, some of these important distinctions in diagnosis with the WHO and the ICC, which are now different, confusing everybody. We'll break it down, check out our show notes, check out our earlier hemepath series, really our first, 6 episodes of our podcast. Excited to get into this one.
Yeah, and with risk stratification, this is something that constantly evolves, so always look out for the latest and greatest guidelines, but this should give you a really good foundation of the sort of things that we're looking for.
All right, guys, well then let's roll that show.
So Ronak, I understand that you are finally a big bad attending, is that right?
I don't know if big bad is the appropriate adjective, but I have started my time as an attending. It's wild, guys.
Ronak strikes the fear in the medical students that he's with, especially the med students. You got to be a little softer. You got to be a little bit nicer.
I wonder if my enthusiasm and love of hematology oncology comes across as very aggressive. I just want to share knowledge and get people excited about what we do. I don't know. But I will keep what you said in mind because you guys are successful, flourishing attendings. And, as the lowest one on the totem pole, I should follow suit for sure.
Our combined 3 years of experience.
Yeah, the combined 3 years of experience. That's right. I will say this is a larger conversation, but the one thing I didn't realize when people start attending time is an immense amount of imposter syndrome. I know that they talk about that a lot when you start residency, even in medical school, fellowship for sure. I felt like that, but I've never quite felt it as much as I do now. And I'm hopeful that's something that goes away with time, but that's the one thing I don't think I was completely prepared for. But I imagine that this is a common occurrence.
No doubt. And just so much reading. Every time you're faced with a scenario, I feel like you're just digging up papers. The learning is just incredibly steep the first several months to years, I imagine.
But you know what's nice? There's a podcast called The Fellow on Call that can kind of help you sort through some of these issues that you're going to have. And that's why we're doing the episode today.
I am so appreciative to be able to fall back on this. Also because if the attending thing doesn't work out, maybe this can become my full-time gig instead, but we'll see. We'll keep one thing at a time. Today, we are continuing on our discussion we started last week. Last week, we talked all about general information about things like CHIP and ICUS and CCUS. And this time, moving along that spectrum, talking and at least starting the conversation about things like MDS and AML. Vivek, do you want to start us off with a case? And that way we can start this super important discussion off.
So we have a 68-year-old male who presents to our hematology clinic for evaluation of macrocytic anemia and thrombocytopenia. CBC today is notable for a white count of 1.6 with an absolute neutrophil count of 730, hemoglobin of 6 with an MCV of 110, and platelets of 43. He notably has had an unexplained macrocytosis for the past 8 years and developed a thrombocytopenia about a year ago. So, we trended these labs like we talked about last week. He has an extensive workup set that we discussed last week, including vitamin B12, folate, copper, HIV, hepatitis C, hepatitis B, EBV, and CMV, which were all normal. He was not on any supplements or medications that could cause marrow suppression. He had no history of alcohol use, illicit drug use, or liver disease. So we planned a bone marrow biopsy to rule out an underlying hematologic malignancy. The impression read the following. There was a hypercellular marrow with trilineage hematopoiesis, erythroid and megakaryocytic dysplasia, and increased blasts 7% by manual differential. These findings are consistent with a myelodysplastic neoplasm with increased blasts per ICC criteria. Cytogenetic and molecular studies are pending. So can we go over how they got this impression in the bone marrow biopsy? And can one of you really walk our listeners through just the key components of the marrow sample that we get?
I feel like this might be the 100th time I've shouted this out, but please go check out our hemepath series if you haven't already. It's the first 6 or so episodes that we recorded for this podcast. It gives a really nice comprehensive overview of all the tests that we're going to discuss throughout the rest of the series. And we have some links on our website to access these through our rotation guides, the Malignant Heme, I think, rotation guide. And we'll make sure that those links are also available on the show notes, but definitely go review that if you haven't listened to it recently. Whenever we get a bone marrow biopsy, there are a few key components that we obtain. So we take an aspirate, which is a liquid marrow sample, like the little greasy particles of bone marrow suspended in the liquid. And it's off that aspirate sample that we get some morphology and cell counts. They kind of do an aspirate smear. We also can get flow cytometry because these are, again, live cells in suspension. And so that can help us identify and quantify really precisely a potential clonal abnormal immunophenotype within the bone marrow. We also use this sample for cytogenetics to look at large-scale chromosomal rearrangements, translocations, things like that. And we can also do FISH on that as well. So there's both karyotype to look at all the chromosomes arrayed and FISH to look for specific rearrangements. And finally, this aspirate is where we do the molecular studies. So this is where we're actually doing our specific gene mutation analysis, just because the fixative that we use for the solid sample tends to denature the DNA, so we can't really run molecular studies once it's gone through that process. The core biopsy is where we take that little chunk of solid bone marrow and we do a cell count and immunophenotype through IHC staining of specific cell surface proteins that can identify things like CD34, for example, if we're looking for the blast count. It also gives us a really good look at the sort of architecture of the bone marrow and the morphology of the cells within their specific bone marrow niche. And lastly, this is how we calculate the cellularity of the bone marrow, because it gives us an overall sort of picture of what percentage of the solid marrow sample is cells. We also use that core biopsy to do touch imprints. So, and you can see the tech doing this in the room. If you ever observed a bone marrow biopsy, they take the core and they kind of dot it along the slide to get these little impressions of the marrow core. And as some of those cells kind of come off the biopsy onto the slide, we can do an additional sort of morphologic review and see if there are any abnormal appearing cells. If you can't obtain a good aspirate sample, and sometimes in like a packed marrow, you can't really get a great aspirate, the marrow is like totally full of cells and you just can't draw anything back. Sometimes we can use an extra core sample if it's suspended in a different type of solution than the standard fixative to sort of shake off some cells and run flow studies, molecular studies, things that we couldn't do off the core biopsy. So that's another alternative. And again, we have additional details in our hemepath series. Ronak, do you want to go through a little bit about what we can see on these different samples? Like what type of cellularity reads you're going to get, that sort of thing?
Absolutely, Dan. And that was a great reminder of the things that we had talked about early on in the show. So another plug, if you're hearing this, go check out the hemepath series. I think the easiest thing is for us to go maybe line by line with what Vivek said on the pathology report. And the first thing that he mentioned was that the marrow was hypercellular. So when we talk about hypercellularity or the cellularity of the sample, this is determined based on the percentage of fat cells to hematopoietic cells, and it's often calculated as 100 minus their age in terms of what is considered normal. So you do 100 minus their age, and that should be what's normal, and then they're comparing how the cellularity of the sample compares to that value. So in this case, the cellularity was higher than expected based on the patient's age. The next thing that he mentioned was a comment on dysplasia. So this is that pathologist using their eyeballs, to use Vivek's term, to look at the cells and identify that they have characteristics of dysplasia. There are specific criteria for dysplasia in the granulocytic lineage, the erythrocyte lineage, and the megakaryocyte lineage that is way beyond the complexities that we'll talk about on this show. There are different parts of the biopsy and the peripheral smear that are then utilized to determine whether or not these cells appear dysplastic. For example, the granulocytic dysplasia is done through the aspirate smear and the peripheral blood smear, but the erythrocyte dysplasia is done through the aspirate smear alone. So in order to call morphologic dysplasia, there has to be more than 10% of the cells in that lineage with these dysplastic features. The last thing that Vivek mentioned was that there were increased blasts, and this is critically important to understand blast enumeration. So the gold standard is the aspirate cell count with differential, and this percentage is out of 500 cells that are counted. So sometimes the touch imprint from the core biopsy can be used if the marrow is very fibrotic and we're unable to get a good aspirate. Flow cytometry is not supported by the WHO for diagnosis because there is a hemodilution process, and lysis of erythrocyte precursors can significantly affect the blast count. One of the other options to do this is IHC on the core biopsy for common blast markers like CD34 or CD117. So these are some of the methods by which we can determine what the blast count is.
This was a really good recap, and I think it's really important that you guys went over all of those key components to the marrow, what we're obtaining. And just to recap one more time, dysplasia, because this is really important when we think about it, and it's very confusing. So when patients have dysplasia, this means greater than 10% dysplastic features. There's pathologic criteria that the pathologists know in a certain lineage, and that's really important. That doesn't necessarily complete our diagnosis of MDS, and the diagnostic criteria for something like an MDS and an AML are currently evolving, and we'll go through some of those details. This syndrome that we keep on referring to, the cancer syndrome of myelodysplastic syndrome, has now been renamed as myelodysplastic neoplasm. But in general, you'll see historical studies calling it MDS. So for the purposes of the show, we're going to call it MDS, but know that it's also called myelodysplastic neoplasm. The other really important thing to note when we think about these myelodysplastic neoplasms is that dysplasia is different than atypia. And it's a very subjective call, which is why we have tumor boards. This is why we talk to our pathologists and ask them, hey, is this atypia? Which has, again, these are just pathologic criteria. Dysplasia is a very distinct set of criteria. And we're going to get more into the fact that, okay, if you just have dysplasia, does this make a diagnosis of myelodysplastic neoplasm or MDS? So let's get into that. So in this case, we had our FISH MDS AML panel come back that showed deletion 20q and 3 copies of centromere 8. The karyotype showed 46XY, deletion 20q, and trisomy 8. Myeloid NGS panel was sent on the marrow sample, which showed a U2AF1 mutation with a variant allele frequency, or VAF, of 38%. That was a tier 1 mutation. And a DNMT3A mutation with a VAF of 42%. That was tier 2. Remember, we talked about variant allele frequencies in our last episode, so be sure to check that out. Check out our show notes if you're confused by that. So what do you make of these findings?
Well, first off, I'm just so glad you mentioned that there's some subjectivity to this and that we talk about this in Tumor Board. Just reading a bone marrow biopsy piece on a piece of paper is not the same thing as having your own pathologist look at the slides and having a face-to-face or Zoom-based discussion about what those findings mean. And this is part of it. Seems wasteful sometimes to be like, oh, get us the bone marrow slides. We're going to have our pathologist read it too. This is why we do that, is so that we can have these discussions, have another opinion. But as far as these findings that you mentioned, a key thing to know is that over 90% of MDS cases will have evidence of clonality with a cytogenetic abnormality or a mutation identifiable on next-generation sequencing, NGS. Morphologic dysplasia can be commonly found as a reactive process, and so we shouldn't always consider that a slam dunk that this is a myelodysplastic neoplasm that we're dealing with. And similarly, copper deficiency can cause sort of dysplastic features. There's a lot of things that can cause that. For example, if you perform a bone marrow biopsy after chemotherapy on a solid tumor patient, they would have low counts and you would probably see dysplasia. So you could fool yourself into thinking that's what's going on. And that's why we have to send off all of these additional studies, these ancillary studies. A large chromosomal rearrangement found on FISH, or karyotype, helps establish clonality, and a somatic mutation found on NGS also establishes clonality. And so if you're ever wondering whether a mutation on NGS matters when you actually read through that report, just know that tier 2 and tier 1 mutations, as they're listed there, will be clinically significant. And mutations in other tiers and lower tiers have not been well described. And so they might be background noise. They might escalate to a tier 1 or tier 2 at some point in the future. But when it comes to risk stratification, tier 1 and tier 2 mutations are the ones that we're really looking for. There are risk scores for MDS that incorporate both cytogenetic features and molecular information from NGS. And we'll discuss that a little bit more in a future episode. But know that in addition to establishing clonality, we're getting enough data on some of these mutations that they can really help inform what a patient's tumor is going to behave like.
This is a great representative case to discuss interpretation of the bone marrow biopsy and to understand this diagnosis of MDS. So, to establish a diagnosis, a patient should have cytopenias, morphologic evidence of dysplasia, which is defined as more than 10% in that lineage, and evidence of clonality through a cytogenetic or a molecular mutation. So, in this case, the report noted this would be MDS with increased blasts. How do we subclassify MDS based on the blast count and the genetics that we just discussed?
This has changed significantly from the 2022 WHO 5th edition and the new ICC International Consensus Classification Guidelines. These are two different systems, and there's one key feature that distinguishes them that we're going to talk about here. It's a very huge change. So the WHO has genetically defined MDS subcategories and morphologically defined subcategories. You might be wondering, why did they separate these things out? The reason is because of prognostication. The second reason is because we know that clinical trial enrollment, very important to distinctly categorize these patients. These are very heterogeneous diseases. And myelodysplastic neoplasm, it's not a one-size-fits-all. These are quite heterogeneous. That's why it's really important that we've done this. So the mutation categories in WHO, we'll list them in our show notes. A couple things I just want to note is SF3B1 mutation. There's one called MDS with SF3B1 mutation. That is always the favorable mutation. There's one mutation that you need to know in MDS. That's SF3B1. That's the favorable one. We'll leave it at that. The TP53 mutation is bad. And the one thing I want to note about MDS with biallelic TP53 and the WHO, this means that there are two mutations in TP53 on the NGS, both with a variant allele frequency greater than 10%, or there was loss of heterozygosity. And remember, we count the variant allele frequency as the total number of mutated alleles over the total number of alleles. And if you lost heterozygosity, that denominator will be a lower number, so your total percentage will be higher. So variant allele frequency of greater than 50% with one TP53 mutation is also considered MDS with TP53 mutation, bad prognosis. The morphologic categories for the WHO are MDS IB1, meaning increased blast category 1, which are 5 to 9% blasts, and MDS with increased blast category 2, or MDS IB2, which is 10 to 19% blasts. And then there's MDS with fibrosis, and that's the WHO. What's different in the ICC? There's one thing. The genetic stuff's the same. Again, it'll be in our show notes, but here's the one difference. It's very important. For the increased blasts, like we said, there's a 5 to 9% and a 10 to 19% for the WHO. For the ICC, there's only one category, MDS with excess blasts, which is 5 to 9%. Patients who have greater than 10% blasts and a defining MDS cytogenetic abnormality or somatic mutation molecular abnormality have what we call MDS/AML, meaning they're defined as having AML. So you do not need 20% blasts to have AML per ICC if you have an MDS-related mutation. And that's clearly a huge change, right? Now in the WHO, we're not treating them like AML. But in the ICC, we're saying, yes, we will treat these patients like AML. This is all very important. Check out our show notes. The big thing, again, to remember, greater than 10%. And what are these cytogenetic abnormalities for MDS, molecular abnormalities for MDS? Don't memorize them. We'll put them in our show notes and look them up. Do not memorize them. No need, right? Always look them up. So now that we know that, what about when we have patients? So let's just talk about MDS in general. And let's say they had morphologic dysplasia, but they have normal cytogenetics and NGS with cytopenias. And, we've ruled out other secondary causes. So what do you guys think? Does that patient have a myelodysplastic neoplasm, or what would that patient be defined by if we don't have this clonal mutation found on our studies?
Well, as I was saying earlier, this is a pretty fraught topic. And of course, it's really important to rule out those potential underlying causes of like a secondary dysplasia on the marrow. There has been some research done looking at this patient population. There was a retrospective study done at 4 academic medical centers which identified patients like this who had MDS and no sort of clonal abnormality found on their genetic workup and cytogenetic workup. The patients that had a diagnosis of MDS but no identified clonal genetic abnormality had a better prognosis overall than patients with clonal genetic abnormalities. And they were still treated for MDS, sort of just like we would standard of care, with appropriate responses. We'll have a link to that in our show notes, that study. So this is a fairly fraught topic. Some hematologists simply don't believe that these patients truly have a diagnosis of MDS if they have dysplasia but no cytogenetic or NGS-identified clonal abnormality. Of course, it's going to be important to rule out underlying cause of a secondary dysplastic appearance in the marrow, but there's some suggestion that these patients could potentially have a true MDS, likely just with a genetic change that we haven't been able to identify or some other issue. There was a retrospective study done at 4 academic medical centers which identified patients like this who had no clonal abnormalities. They were treated just like other MDS patients that did have those abnormalities, and they were shown to have appropriate responses still. They responded just like a patient with MDS did. Now, they had better outcomes and a better prognosis overall compared to MDS patients that did have an identifiable clonal abnormality. But the fact that they responded as though they had MDS is pretty convincing that that might be their true diagnosis. Last week, we discussed that peripheral blood NGS is an adequate study to do on patients who you may suspect MDS in, because all those just downstream mature cells that are produced from the myeloid hematopoietic system, they would have picked up that mutation from the abnormal stem cell. And so they too would carry the mutation in their genes. In most cases, we consider peripheral blood NGS good enough, but there is a roughly 5% rate of false negatives, based on a study published in Blood, which we'll also have a link to in our show notes. And that's why marrow NGS is really ideal if you already have done a bone marrow biopsy. You might be thinking, well, why do we even bother with doing NGS on the marrow if we're also just able to run this on peripheral blood? You don't want to miss that small segment of folks that may not have adequate coverage on their peripheral blood studies. And so it is still important to send the NGS on the marrow if you've proceeded to getting a bone marrow biopsy.
That's perfect, Dan. And I think that's a good discussion for MDS for now. So let's move on to another case. So let's actually talk a little bit about the AML diagnostic criteria. So let's say we have a patient, pancytopenia. They came to the ER because they felt really, really poorly. Their CBC showed a white count of 22, a macrocytic anemia, thrombocytopenia, and as hematologists, we looked at the differential on our electronic medical record. The neutrophil count was 400, and 85% other cells were reported. So, Ronak, what do we do from here? What do you think about that?
I'm getting flashbacks to first year of fellowship listening to this case presentation because I felt like this was so common, especially on the liquid service. But the most important thing here is that we need to understand what actually are those other cells that are noted on what you just described. And when we think about acute leukemia, those immature cancer cells are what we call blasts. And so that is the big thing that we're trying to convince ourselves is present or not present, is are there blasts in circulation? Is that what the machine is reading as other cells? So remember that the manual differential report is done by a technician or a pathologist who either believes the cells look morphologically like blasts or there might be blasts, but they're not quite positive. And that's what the person is trying to figure out. In either case, our eyes are not perfect. And so remember that flow cytometry is the best way to confirm whether or not these cells are truly blasts. So flow cytometry will look at those phenotypic expressions of what markers are on the cell surface. And abnormal cancer cells will aberrantly express certain markers and certain atypical markers that maybe are not there, even though they should be there. So remember that flow cytometry basically looks at what's on the outside of the cell. It's trying to characterize the phenotype of the cell. If your differential and peripheral smear is entirely normal, then peripheral flow cytometry is actually less helpful because you have no major population of cells circulating to identify an abnormal immunophenotype. So at that point, you're likely headed to a bone marrow biopsy if your non-invasive workup isn't really showing you what you need to do, and especially if it's all normal. Because at the end of the day, as you mentioned, this patient still has significant cytopenias, and so it may be that the bone marrow biopsy is going to be the most logical thing to do if you don't have an answer otherwise.
So we sent this patient to the emergency department because he really didn't look that well and needed a blood transfusion. And we sent off that flow cytometry in the peripheral blood because we wanted to characterize all of those circulating other cells. And the report showed increased myeloblasts that were 85% of the total cells with the following abnormal immunophenotype: positive for CD4, positive for CD33 bright, positive for CD34, positive for CD117, and positive for HLA-DR. The big thing to know here, CD34 means blast, and CD33 is a myeloid marker, hence we have a myeloblast. There are charts you can look up, and always look these up. Again, check out our early hemepath series. So let's focus on diagnostics testing for AML here. Let's not talk about the acute management yet. So this patient ended up getting a bone marrow biopsy, which showed a hypercellular marrow with increased myeloblasts greater than 80% that was consistent with acute myeloid leukemia. Cytogenetics and molecular studies are pending. So we'll give you more details from this case in our later episodes when we talk about risk stratification and treatment in these acute leukemias, which is really what we're using that cytogenetic and molecular information for. But how do we diagnose AML? What are the diagnostic criteria for AML? We alluded to it a little bit earlier. Dan, can you walk us through what are some of the diagnostic criteria for AML?
The one that I always remember is greater than 20% blasts on the smear, either the peripheral blood or the marrow smear. But there are some other criteria that we can go for. So if there is a characteristic cytogenetic abnormality that is, quote, AML defining, then we consider that to seal the diagnosis of AML regardless of the blast count. The ones to remember are translocation 821 and inversion 16, which are core binding factor AML. We'll talk about that means in a later episode. And of course, translocation 1517, which is characteristic of acute promyelocytic leukemia. So if you see any of those cytogenetic changes, then that defines AML, again, regardless of what the blast count is. We're also now incorporating some NGS information. So if there are characteristic molecular abnormalities on NGS, again, regardless of blast count, including NPM1 mutation or CEBPA mutations in the BZIP region, those define AML if you see them. Additionally, just some less common ones, if you biopsy a solid mass and it's shown to be myeloid sarcoma, most of the time these leukemias are liquid tumors, but sometimes those AML cells form a little ball. It used to be called a chloroma, I think, because they have like a greenish appearance. If you do find that, if a biopsy of a solid mass comes back as myeloid sarcoma, that is also defining of acute myeloid leukemia. And lastly, we have this population of folks who would be considered MDS under the WHO criteria, but they have an MDS defining cytogenetic or molecular abnormality and greater than 10% blasts. Now, by ICC, that would be AML. But again, there's this tension between these two guidelines. So I think we have to consider that AML just because if you can diagnose somebody as having something more intense, generally that's what we go for.
I'm dying to know some historical context here from our resident historian. Why did the change in the blast count happen? Why did the WHO criteria differ from the ICC criteria? And also, we have alluded to the fact that there's a distinction between MDS-related AML, which we now call MDS/AML. Why are we making this distinction? What does it really matter if they've had MDS prior and now have AML?
That's a really, really good question. And the key thing to know, if we go way back, we used to have the French, American, British criteria, the FAB criteria that a lot of us learned about in medical school and studying for the step exams and things like that we never talk about nowadays because all we had was morphology. We didn't have all this genetic information. Then as we did retrospective studies in large databases, sequencing the samples, understanding the genetics, there was cytogenetic risk stratification for these patients. And we'll talk about that in our future episodes, but that happened. And the big question is, well, why do we keep on, what do we have, WHO 4th edition, WHO 5th edition? Why are they different? What is happening here? And the big thing to know for this MDS/AML, or for what WHO calls it, is AML-MR, or myelodysplasia-related AML, is that these were inclusion criteria for clinical trials. And that's really important, right? It's a distinct population of patients. We don't call all squamous cell lung cancer is different than lung adenocarcinoma. This is the same concept here. AML with myelodysplastic related changes or evolving from a prior MDS is different than de novo AML with an NPM1 mutation. These are different diseases. It's quite heterogeneous when we think about that patient population. So why did this change come? When we looked at risk stratification in MDS, and we had this revised IPSS score in MDS, if you look at the supplementary appendix, which we do at the Fellow on Call, and we'll talk about this more in our MDS episodes, we knew that those patients who had 10 to 19% blasts did the same as patients with greater than 20% blasts if they had these MDS-defining genetic abnormalities. So the question was, why aren't we calling them AML? Prognostically, they do the same. We should treat them with intensive chemotherapy. It's the same disease. It's so subjective. What if you had a cluster of blasts, did your biopsy, and you underestimated the count because you missed that cluster of blasts, right? These are really, really important things. So these updated classifications allow better access to clinical trials. It allows the provider to treat the patient as an MDS patient or an AML patient. But overall, based on the data that we've known since the revised IPSS and MDS, patients with 10 to 19% blasts who have these genetic abnormalities do the same prognostically as those with AML. It's essentially the same disease. The genetic driver of the disease is the most important component here, right? And that's why this distinction was made. And this is why the ICC said, let's call it MDS/AML, so we can include patients in different clinical trials, and the provider can have the judgment on how to treat this patient based on their genetic features.
That's huge. I can understand why these distinctions are being made. I think certainly from the perspective of people that don't do this every day or trying to learn this for the first time, it certainly makes things a little bit difficult. But I think this sort of background really helps, especially as we refer back to trials and studies that we're going to be reading while we take care of patients, even from just a couple of years ago. Some of that terminology will be different, and it's important to be cognizant of what these conversations had been in the background. So thank you for shedding light on that. Guys, I think that this really was a great episode to really lay the foundation for the subsequent episodes to come. I think that we have a really good understanding after this episode about the kinds of things that we're looking at and paying attention to on that pathology report in order to get the necessary information to appropriately risk stratify our patients, even as far as MDS versus AML, and then within that, the kind of changes that we're looking for to help further categorize patients into, the appropriate risk category. So I'm excited for this conversation to continue in the next few weeks. But any final thoughts that you guys have?
No, I thought it was a great episode. Looking forward to get into the core of treatment and further risk stratification using these cytogenetic and molecular abnormalities.
I think that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.